Hello, everybody, and welcome to today's talk on the Medicare Access and CHIP Reauthorization Act, hereon lovingly referred to as MACRA. My name is Rohan D'Souza, and I'm with eClinicalWorks' Population Health Management team.
And I'm Adam Salati, Business Analyst.
Today, Adam and I have a lot to talk to you about MACRA, and we're going to try and make this simple and easy to understand, so let's try to set some context. We're embarking on a pretty exciting journey. MACRA is making a monumental shift towards rewarding better care versus more care. One of the biggest changes with MACRA is the overlapping of programs or the consolidation of multiple programs into a single quality payment program, or QPP. And last but not least, we're going to talk to you about some options for you to take part in this pretty exciting initiatives, specifically as it pertains to the merit-based incentive payment system or the advanced alternative payment model. A couple weeks ago, CMS dropped the news that MACRA has now been finalized. It's been talked about a lot in the annals of public health, population health, all over the news. I feel like everywhere you go, you hear MACRA, and it was finally dropped on us a couple Fridays ago. A couple news articles picked it up, and really Adam and I want to give you a sense of what MACRA helps us understand with the payment reform that's coming into place.
Rohan, I just want to say, I think it would be great at this point if we had some sort of visual overview of what MACRA, what it is. What's the breakdown? Do we have something like that?
Yeah, maybe something like this.
Oh my God. Oh, this is going to be bad. This is going to be a mess. Rohan, what are we going to do about this?
Adam, that's exactly why I'm here, buddy. Today, we're going to spend some time really trying to help Adam out, but also more specifically all our listeners out there, understanding the subtleties, the nuances, and potential complexities with MACRA, specific to the merit-based incentive payment system up at the top, and we'll touch a little bit about the advanced alternative payment models down at the bottom. This diagram is going to be something we'll always refer back to as we continue along with this conversation. So let's try to remove that anxiety, Adam, and let's move on to try to convert this into a smiley face. So the important thing to note is that under MACRA, it gives us two options. Like I talked about, we're going to be focusing on MIPS specifically in the majority of our discussion. MACRA really gives us a change in how we look at three things we're already very used to. I think everyone that has anything to do with Medicare patients or Medicare reimbursement really understands meaningful use, the value modifier, and PQRS. What Medicare is now saying is that they're going to consolidate that program into one single endpoint. So no longer are we going to necessarily look at meaningful use, the value modifier, and PQRS as being completely independent of each other, but we're going to consolidate this into one overall program called a QPP, or the Quality Payment Program. So talking about MIPS, which I think 95% of people are going to be responsible to report on, think of this, Adam, as one big mathematical equation with four variables. Each of these variables holds some weight. When added up together, they provide you with a final score called a MIPS final score, which we'll talk about as we go into this presentation. So really what I'm trying to say, Adam, or I'm asking the question of myself and of you, is this really the same thing, but maybe with a new modified look?
Yeah, Rohan, I'm really kind of getting that feeling, especially with the concept of the former programs that we're already used to, kind of combining into this one program and looking at the components there, tallying up to a final score. It really does feel that way. It kind of almost feels like, maybe when we went to go see that first Star Wars movie, and they were trying to save the planet by destroying the space station, and then several years later, because everyone loved Star Wars so much, they're coming out with a new movie, or they came out with a new movie, and then we had to do the same thing, kind of. So is that kind of what you're talking about, Rohan?
Yeah, I think that's a fantastic analogy. Maybe something a little bit more personal to me is what just happened with the iPhone. We went out there, stood in line, got the new iPhone. You come back home and you realize, my God, this is really not that much different than the one I've already had in the past. Sure, they got rid of the home button, But is it really that much different?
Oh, you fell for it, Rohan.
I sure did. So let's move on, guys. Let's talk specifically about who needs to now just take a pass, or who gets to take a pass with MIPS. Similar to most other programs that CMS offers, if you fall into the exclusion bucket, which means if this is your first year, or if 2017 is your first year of billing Medicare under Part B, or if you have less than $30,000 in Medicare reimbursement for the year, or less than 100 patients, or if you qualify into an advanced alternative payment model, you get to bypass this mathematical equation of MIPS. Of course, RHCs, CHCs, and FQHCs are not included in the first year of MIPS, but there is some legislation out there to potentially have them introduced in some shape or form. So, we'll keep watching that pretty closely. As we talked about in the early half of this discussion, or the early parts of this discussion, we talked about a mathematical equation where simply we're taking variables to come up with a final score. This particular slide talks about the opportunity for a practice to score a high level as it correlates to an equation of x divided by y, where y is the total number of points a practice could get, and x is the number of points the practice actually did receive. When you divide those two out, you get a final score, which determines ultimately what your payment modification is going to be. We'll follow this along in every single variable we touch. So as we talked about, MIPS is the inclusion of 4 variables, or really the consolidation of 3 programs with the addition of a new program called improvement activities into one final score that is distributed out to the practice. What CMS did in the final ruling is they actually removed the weight associated with the claims-based cost factor for year 1 under MIPS, which means although CMS will still calculate your cost and utilization, they're not going to include the outcomes from that factor into your final score. To talk about this in detail, let's cover the first item, which is the quality performance category. This particular category accounts for the most amount of weight towards your final score, a whopping 60% of the overall available 100. Luckily for most practices, the QPC is nothing but PQRS. Practices are well aware of the options under PQRS and will be familiar with the principles applied within PQRS to score under QPC. To talk about that with a little bit more detail, every measure has 10 available points. Non-reported measures account for 0 points, but then practices have the ability to secure some bonus points, which Adam, I'm sure you're going to get into detail as we move along, to come up with a final score.
Right, so let's discuss the details of how we arrive at that particular score. First of all, we're going to be selecting some measures, okay? There's 70 possible points, and what we're going to be asked to do is look through a menu of quality measures, quite long, 270 measures, come up with 6 of them that we can do or think we can do, and then make sure that out of those 6, at least one of them is an outcomes measure. Now, if you find yourself in the position where there's an outcomes measure or there's not an outcomes measure that applies to you, I should say, you can always choose a high priority measure as well, and those are quite easily found on the CMS website, qpp.cms.gov. There's some really handy filters there. They allow you to filter by specialty and subspecialty, and you can find the quality measures that apply to your situation. Now, the nice thing about that is that if you find yourself in a subspecialty where there are fewer than 6 measures available, you will only be accountable for those particular measures. If you have more than 6 available, you'll only be asked to report on 6. For some specialties, maybe like dermatology, that found it very difficult to do some of the reporting under PQRS, you'll hopefully be happy to find that your list has expanded to give you some more flexibility and hopefully be more meaningful to you. Now, once we've chosen our measures, we're going to have to score those measures, okay? So we're going to report some performance to CMS, and then based on that performance, we're going to be placed into deciles. An important thing to note here in the MIPS MACRA era is that as opposed to meaningful use, where we were scored in a vacuum, we were given a threshold, we either had to meet or beat that threshold in order to get credit. Here in MIPS and MACRA, we're actually going to be comparatively scored against other participants. Okay, and of course that'll be based on historic information aggregated and grouped according to different calculations. But like I said, the important thing to note is that we're going to be comparatively scored and placed into deciles, which will earn us a corresponding number of points. Let's look at an example here where a practice may have chosen several of their measures. We've calculated the scores for all of those, but to make it simple, we're just going to look at the total score here. So we've done the calculations. We've come up with a score of 48.2 out of the 70 possible points. But it's not over there, because now we want to start looking at our bonus points. If you noticed in that list, we had, I believe, one outcome measure and one additional high priority measure. That additional high priority measure is going to give us an additional bonus point. But beyond that, we also had some end-to-end reporting being done. So from your EMR vendor electronically to CMS, meeting all of the qualifications and requirements thereof, we were able to earn 3 additional bonus points. Now, eClinicalWorks, as an EMR vendor, a company that helps store your data and record your data and report on your data, is seeking clarification and certification from CMS as we speak to try to get as many credits for end-to-end reporting as we possibly can. Keep your eyes open for more information as we go through the program here. But we're going to assume that we earned a few of those and add those to our combined measure score, and now we have 52.2 out of 70 points. Now, we've gotten our measure points. We did have at least one measure in our example where we didn't report anything. We got 0 points for that. We have got a couple bonus points, and we arrived at our total score. Taking that total score out of our total possible points, we've earned 74.6%. Now, keep in mind again that this 74.6% is going to be weighted, and it's going to be combined with our other categories to come up with our MIPS final score. You can kind of think of it as arriving at a grade point average after you've gotten the grades for all of your individual classes. And we'll see how that progresses as we go through here.
Adam, thank you for that rundown. So let's put that aside for a bit. We have covered 60% of your overall weight towards your final score under the MIPS category. And let's talk about another, should I say, acquaintance or more than acquaintance. Practices are very familiar with our good friend Meaningful Use, and Meaningful Use is going through a rebranding and is now going to be called Advancing Care Information, or ACI. This particular category accounts for 25% of the total weight towards the MIPS final score. Under the ACI category, very similar to the quality category, practices have the ability to score a certain number of points, and after they score those points, have the ability to score some additional points or bonus points to come up with the final scoring. What's different about this particular category is that practices need to achieve a certain baseline. We're going to call this your base score, where every practice has to at least achieve the 50 points on these base scores. Once that's complete, the practice then pursues their performance score, where they can get the additional 90 points, and then finally tack on some bonus points to really get you the highest available point total within this 25% category. So Adam, can you walk the folks through this misconception that a lot of people have? Just because MACRA and MIPS is now coming down the pike, is Meaningful Use essentially going away?
You can tell Rohan and I are from Boston because he mentioned the pike as opposed to the pipe. But Rohan is absolutely correct. As we said before, MACRA really rolls some existing programs together into one to try to streamline the process for participants. And part of that is going to be the concept of EHR certification. This is going to continue going forward. In the 2017 performance year, physicians can report using either a 2014 certified EHR, that's stage 2, or a 2015 certified EHR, that's stage 3, or some combination thereof. What that would mean is that providers would be able to choose which measures they report on accordingly. Now, eClinicalWorks for the majority of 2017 is going to be a stage 2 certified EHR. And again, we're seeking Stage 3 certification as we speak. We expect that to be available sometime in the mid of next year to maybe the third quarter or fourth quarter of next year. So plan on reporting on the Stage 2 measures for MACRA. We're going to take a look at those in just a second. In 2018, however, all participants will be required to use a Stage 3 certified EHR. And as we said, eClinicalWorks should be Stage 3 certified within plenty of time to get that done for you. As Rohan mentioned, there is a base score component to the ACI category. The base requirement here is very simple. If we do any kind of reporting on these 4 items, we're going to earn the base score. That's 50 points. You see that in the top right of your screen. A lot of these items should be very familiar, especially if you've done meaningful use. Protect your patient health information, that's doing your security risk analysis, giving a report on the numerator and denominator of our electronic prescribing, sending summaries of care, and providing patient access to our patient portal. These are going to be very simple to do. You only have to report a denominator and any numerator to CMS to get the 50 points for this category. If you miss any one of these 4 items, you're not going to earn the base score, and consequently, you're not going to be evaluated for your performance score. But as we said, it's going to be very simple to do because you just have to send them any kind of data on those 4 items. Now, we're going to look at the performance category. So once you've earned your 50 points there are an additional 90 points available for some performance items. Now, the good news here is that 2 of our items were actually components of our base score. So hopefully we've been doing those and doing those for long enough that we have a decent score there. Sending summary of care and providing patient access are also components of our performance score. And as an additional bonus, those 2 items are actually worth double what the remaining items are here at the bottom of our screen. So there should be plenty of points to go around. To round out our category here, we have view, download, and transmit, secure messaging, patient-specific education, medication reconciliation, and immunization registry reporting. Now, many of those items, again, should be very familiar if we've been doing meaningful use the past few years, so you should hopefully have a good head start on those. Immunization registry reporting, not every practice is going to do that, and that's going to be okay. If you get a no there, you won't get any points for that particular item, but there are still plenty of points to go around, and we're going to take a look at an example of that right now, or coming up soon. Rohan also mentioned some bonus points, so let's talk about what might earn you some bonus points under the ACI category in 2017. Submitting data to a specialized registry or performing syndromic surveillance, if your EHR has those capabilities, will earn you up to 5 points for either of those activities. There's a third category, improvement activities, and as Rohan mentioned before, this is actually another category which is going to contribute to your final score under MIPS. So if you are doing any of those activities, those improvement activities that cross over here to the ACI category, you can earn 10 points for those. Let's take a look at a scoring example here. Our example assumes that our practice did the very minimum, or at least the very minimum, to earn the base score points. They attested that they do a security risk analysis, and they submitted at least some information for the other 3 items in their objectives and measures and got that 50 points. Now, we've tabulated some additional performance score components, putting in some numbers here for the sake of an example. This practice did not do immunization registry reporting. It's just not something that the practice does, so they earned 0 points there. But tallying up the rest of their score and adding in 5 bonus points for specialized registry submission, they got a total of 111.5 points. Now let's take a look at that in context of the overall category. When we combine that total score to the total possible score, we find that we've actually gotten above and beyond the maximum number of points. So we're going to be capped there at 100% of the ACI category. When we do the weighting, that's going to turn into 25 points to our final score.
Great explanation there, Adam. Thank you. Sounds like that was definitely a case of being an overachiever, where you went above the 100-point maximum scale. So good on you there. The next activity, or the next variable in that equation, is something completely new. But is it really new? What CMS is saying is that although they haven't applied any weights to protocol and process changes within a clinic, most of our customers, especially in the primary care setting, have been pursuing things like patient-centered medical home, performing care coordination and care management activities for quite some time. CMS says that they should be credited for those activities that are being performed day to day within their offices. And that's really what the improvement activities category is. So rounding out the last 15% of the overall MIPS final score for the year 2017 is something called improvement activities. What this is a category that allows a practice to choose certain activities that mean something to their practice. These activities have been tagged as medium value activities or high value activities. A practice can choose to pursue a certain number of medium activities and a certain number of high value activities, or just focus on high value or just focus on medium. The goal of this particular category is to secure at least 40 points. Your high value activities account for 20 points each, and your medium value activities account for 10 points each. To give you an example, here's what some of those categories look like. So under the high value activity side, it's things like providing 24/7 access, participating in a systematic anticoagulation program, or a diabetic patient advanced care management and reporting program. And some examples of the medium value activities are the use of telehealth, the ability to do coordination with a rural health clinic or a federally qualified health center, or the improvement of health status within your communities. For those practices that are considered small in size, according to CMS, which is 15 and under, you actually get a bonus in this particular category. And that bonus is a double value factor for each one of these activities. Which means, Adam, if I'm only selecting one high value activity, it essentially gives me 40 points instead of the 20 points. And if I select two medium value activities, instead of getting only 20 points, I now get the overall 40 points. For folks that are already doing these types of activities within their existing patient-centered medical home or their advanced alternative payment model, they essentially get a bypass on the MIPS category of improvement activities. Since practices that are already functioning as a patient-centered medical home or an advanced alternative payment model have these activities at the core of their business, CMS just assumes that they're doing a whole bunch of these activities and do not need these practices to now pick out certain categories or activities within this particular category.
Now it's time to talk about that final component, the cost component, which again is not going to be part of the 2017 MIPS final score for participants, but it will start being a factor in 2018 and beyond, eventually becoming a large part of your overall score. In 2018, the cost component will start counting for 10% of your final score, and then in 2019, it will count for 30% of your final score. So it's important to try to take this year off as a good way to get a head start on that. For those of you who may be worried about how to calculate the cost component for your practice, CMS is actually going to do that for you based on claims that are associated with your attributed patients. A great way to get an idea of what your cost component might look like would be by downloading your QRUR report from CMS. That's the Quality Resource Use Report. It's available, it's free, and you can get an idea of what CMS will be looking at when they evaluate the cost component for your practice. Now, as Rohan has mentioned with the improvement activities area, getting the double weight there for some of those items, and as I've mentioned here with the cost component not being a part of MIPS for the first year, you can really consider 2017 as an on-ramp. CMS is really trying to make the transition from these disparate programs to a more consolidated, centralized program as easy as possible as they can for practices. Once that on-ramp year is over, however, you're going to quickly need to ramp up to meet the expectations across all of your categories. As you can see here, the cost component becomes a much greater portion of your overall score, while the quality component becomes a smaller part of your overall score. So now the question becomes, what information do we need to get to CMS and how much do we need to send them?
So Adam, let's try to make that a little bit easy for our listeners and give them a couple options. Or really, let's relay the message that CMS put out in its final ruling. Let's call these option A, B, C, and D, with A being considered a trial and experiment, B being a late start, option C being you're completely ready to go, and option D is you are taking part in an advanced alternative payment model. For providers not ready to participate in MIPS, CMS is saying you should at least do the bare minimum or a very small amount, as little as choosing just one quality measure under option A. This is really created for those practices who only want to participate with partial data and will avoid a negative payment adjustment starting in 2019. CMS is saying just submit any data from January 1 of 2017, and as little as one quality measure avoids that negative adjustment. In option B, CMS is offering those providers and groups to perform somewhat of a late start. Essentially what CMS is saying, you need to pick a minimum 90-day consecutive reporting period to submit your data over to CMS under MIPS. The longer you wait, the more time you have to set up processes within your clinic to make changes towards MIPS. But remember, the last date you can absolutely wait and push this back is October 2nd, because now you're entering the last 90 days of the year 2017. Option C is for those practices that believe they're fully ready to go, and the practices that CMS actually believe will have the most amount of participants taking part in the MIPS program. Option C allows for your ability to gain the highest positive reimbursement modification, because you now have the option to report on more than just the minimum 90 consecutive days and the ability to report on more measures, increasing your chances of that higher reimbursement. You must start and participate in reform starting January 1 of 2017 for the QPP. And option D is really where I think most practices and providers are going to start to look to go into. This is the Advanced Alternative Payment Model, which includes things like the Accountable Care Organization Act, called Medicare Shared Savings Programs under CMS. Today includes Track 2, 3, Next Generation ACO within the Advanced Alternative Payment Model piece, but starting 2017 to be included in 2018, CMS will introduce a new track for folks to take part in a dual-sided risk model to be qualified under the Advanced Alternative Payment. The other is the 14 regions CMS selected under CPC Plus, certain bundles like the ESRD, the Oncology Care Model, the recently announced Vermont All-Payer ACO Model, and other types of advanced alternative payment models that CMS will come up with beginning January 1, 2017, all the way on to 2022. The biggest advantage with this is you're guaranteed that 5% incentive payment with your MIPS adjustment. But of course, you do take some downside risk within the confines of each of these programs.
Now that we've talked about how much information to send to CMS to participate in this MIPS component, we also want to talk about how we're going to actually deliver that information. And there are going to be a couple ways available: the CMS web interface, claim submission, qualified clinical data registry, and submission through your EHR. Now, if anyone had participated in meaningful use, maybe waited till the last minute and signed into the CMS website to enter numerators and denominators and exclusions and all sorts of information, that was the CMS web interface. Now, with the combination of the programs coming together, obviously that's going to be multiplied by 3 or 4 times for each component of the MIPS score. And the AMA estimates that for a practice between 2 to 9 physicians with a certain assumed amount of claims and other assumptions built in, that the total annual burden would be somewhere around 88 hours or $8,000 for that practice. Comparatively, the EHR submission component will be by and away the easiest method to do so. And eClinicalWorks, as your EHR vendor, as a group that helps you to store your data and report on your data, we're seeking all of the options there to be able to submit through EHR for you in a timely manner. For more information on this, you can visit the AMA website and use the readiness assessment to see what impact you might expect under MIPS. Now, another key component of the MIPS concept and the evolution from meaningful use in PQRS to MACRA is that there's going to be more flexibility built in. There's going to be no single path to excellence through MIPS. As we can see here in our example, you might have one practice that goes all the way with the quality component, also does the improvement activities, but just doesn't have time for the advancing care information, or maybe they missed reporting on one of those base components and missed out on the entire category. In our example here, they've actually scored the same as a group that spread their attention across multiple categories here. So MACRA really is intended to give you more flexibility so you can focus on what's important for your practice, what's important for your patients, and what makes the most sense, maybe according to things that you've been doing already, so that you don't have to make major changes to participate in the program. Now, in 2017, we're going to be reporting all of this information to CMS. Hopefully, we're going to be participating in doing that. But what we've talked about so far is Performance Year 2017. Under MACRA, there's going to be a delay between the time that our performance is measured and the time that we see adjustments show up with regards to our claims and our billing under Medicare Part B. That's going to be about 2 years. It's going to take CMS 2 years, 1 year to evaluate, and then a second year for your adjustments to start showing up. So any of your performance in 2017 will actually affect your 2019 claims. Now, if we are able to participate in the program and do well in the program, we stand to receive upwards of a 4% positive adjustment on our claims submitted in 2019 based on our performance in 2017. If we don't do well, we may be subject to upwards of a negative 4% adjustment on those same claims in that performance year. And as we'll see in a little bit, it's going to be very easy, especially for this first year, to avoid that negative adjustment. Now, practices that do exceptionally well will be placed into a higher tier under MIPS. And CMS has set aside a bonus pool, a pool of about $500 million each year for the next several years to be divided among exceptional performers. We're going to take a look at what that threshold is in just a little bit, but that's going to cap out at 10%. So in the 2019 performance year, if we find ourselves at the very top of the performance list, we stand to see maybe upwards of a 14% positive adjustment on our claims in that year. Now, this is going to happen year after year. And in 2018, we're going to report our data again, this time with the cost component added. And in the years beyond that, we will see adjustments increasing and potential penalties increasing as well. And that bonus pool will still be there, at least for the first few years of the program. Now, Rohan's going to discuss some more details about those performance thresholds and what it might look like for a practice making some assumptions.
So Adam, keeping with the same assumptions we made on the best use of time when reporting data back to CMS, you talked about the options as a registry, as an EHR submission vendor. If we use that same concept, we can see that that particular practice could stand to make additional $52,000 if they top out at that 4%, but if they choose not to participate in MIPS, can stand to lose $52,000 beginning in the year 2019. And CMS introduced those thresholds to us recently in the final ruling as saying any practice that is between the 0 to 3 percentile of the final score will receive that negative payment. Essentially saying if you do absolutely nothing under MIPS, the likelihood of you getting a negative payment adjustment is pretty high. If you do even a little something, which means you are in that 3 to 70 range of the final MIPS score, you stand to make at least a 0.5% positive payment adjustment. Now, of course, if you cross into that 70 to 100 tier, you could stand to make a pretty substantial amount more than what you were receiving under your pre-MACRA days.
It's also important to note that since we're dealing with comparative performance, the requirements that we're going to be asked to hit or the deciles that we're going to be placed into, as we talked about before, are going to hopefully shift upward. This is where the average performance of providers comes into play. As providers participate in this and as hopefully scores increase and hopefully correlate to better care and lower costs for our patients, the performance targets are going to move up as well. So if you don't get started now, you're not going to see your adjustments until 2019. And by then, the target that you're going to be expected to hit is going to be that much higher. So it's important to get started as early as possible. Do what you can. If you've been doing these things already, it shouldn't be too difficult to adjust to this current program. But if you haven't done anything yet, submit some data, just anything to get that 3-point threshold. What we're looking at here is a comparison of the penalties under MIPS versus the penalties under the separate components of the MACRA final rule. It's never fun to talk about negative adjustments, but here we can see that under the combined program, the penalties are actually much smaller, at least for the first few years. If we were to take a look at the penalties under PQRS, value-based modifier, and meaningful use combined, that would be upwards of an 11% penalty for people who just refuse to participate in any of those. If you don't submit any data for MIPS under your first performance year, 2017, and here we're looking at the payment year of 2019, that's the only way that you'll get that negative 4% adjustment. Going forward, though, as the program matures, the potential penalties become steeper. Now, CMS has also realized that smaller practices may have more difficulty meeting the MIPS criteria than larger practices. And as Rohan mentioned before, 15 providers is the cutoff point as far as CMS is concerned with regards to MACRA. If you have 15 or fewer providers, you're considered a small practice, and there are some adjustments and alterations to the requirements to hopefully make this a little bit easier for you. In the quality component that we discussed first, you won't be evaluated for the population health measure of all-cause hospital readmission, so you won't be evaluated based on that. Practices of 16 or more providers will be evaluated for that, but CMS will calculate that for you on your behalf based on your claims. So there shouldn't be an additional reporting burden even for larger practices. In the improvement activities category, small practices will have double weight for any of the activities that they participate in. So that's where Rohan mentioned that your high value activities actually count for 40 points and your medium value activities actually count for 20 instead of the standard scoring. In the advancing care information component, there really are no changes there. Meaningful use has been around for a while now, so hopefully we're all familiar with that and excelling there. Now, additionally, CMS is setting aside some funds to help these smaller practices with technical assistance and other programs. So do some research on what CMS might be offering for you in your area or in your situation to see if they have some things available there.
The one thing that often comes up is change. Change between place of employment, group status. And what CMS essentially is saying, if a provider chooses to leave a group that he or she was once a part of, CMS will follow the provider's NPI to apply the appropriate adjustments that were applied to the provider when he or she was part of that group. So CMS knows, and they've got the skills to track you down based on just your NPI, even though you might have been reporting as a TIN within the group. eClinicalWorks is providing customers with an integrated MIPS dashboard to really help throughout this entire process. We've always been on top of offering solutions, whether it came to PQRS, whether it came to meaningful use, or other types of quality initiatives. We're following CMS's trend here, and we're consolidating that into one customer-facing product. So as an example, this is the MIPS dashboard that will be available within your eClinicalWorks environment. You should be having that beginning in the early part of the year. You have the ability with this dashboard to look at scores as they apply to a single provider under quality, potentially as a small group, or even as a larger group, and how these providers within these groups compare against each other. There's lots of configuration built in for you to choose your improvement activities as defined in the 93 improvement activities. There's a lot of customization available to allow you to choose your improvement activities, one of 93 in the catalog that CMS is publishing. And then also the ability to look at this data at a provider level and drill down into information associated with the patient. Stay tuned for more webinars specifically about the MIPS dashboard from eClinicalWorks.
Now, another thing that CMS is discussing is the idea of virtual groups. As we knew from PQRS and meaningful use, we might have been able to report as a group rather than an individual. And that would entail reporting the performance from multiple NPIs as one TIN. And then the performance would then be aggregated and the resulting score would be applied to all the participants. Now, to help small practices with this idea, CMS is proposing virtual groups where multiple NPIs and multiple TINs could join to again submit an aggregated score. This would be potentially limited to groups with 10 or fewer physicians, and we realize that that's a different threshold than that's set in the small practice designation. But regardless, this isn't going to be even implemented in 2017, so there's some time to get some more details about this and figure out how it might affect your group. If you are a small practice and you find that it might be difficult to do some of these things on your own, you can look into the idea of forming a virtual group with some other providers in your area that you can use to offset some of your deficiencies and you can use to lend some of your advantages to. Now, earlier we discussed the idea of completely avoiding the MIPS track by participating in an alternative payment model. And in the final rule, CMS distinguishes between alternative payment models and advanced alternative payment models. All APMs will use a certified EHR. All APMs will base payments or incentives on quality metrics, but it's only the advanced APMs that are going to apply a financial risk to their model, in which case they might be responsible for sending money back to CMS if they don't save money in the system. If you are in an advanced APM, now the question becomes, in order to get out of MIPS, am I a qualifying participant? Am I a QP? The determination here is going to be based on a threshold of either your Medicare Part B payments or your Medicare patients that you're attributed through your APM. Now, in the best case scenario, you will be a qualifying participant and you'll qualify for that 5% bonus from CMS and you won't have to report MIPS at all. If you don't meet that qualifying participant threshold, you could still be a partially qualifying participant, in which case the threshold's a little bit lower, as you see on the slide. And in this case, you have a choice. You can either opt out and choose not to report MIPS, in which case you would have no positive or negative adjustment, but you could also choose to opt in, and you can actually send data for MIPS and hopefully qualify for a positive adjustment. And if you decide to opt out, you don't have to do anything. You don't even have to send CMS a notification that you don't want to participate in MIPS. You just don't send them any data. If you want to opt in, obviously you can send them the information. And then finally, if we don't qualify as a qualifying participant, we will have to report MIPS and we will be subject to any potential positive or negative adjustments accordingly. Now, the determinations are going to be made at several times in the year. There are some dates here on the screen, but the determination is a little bit more complicated than that. If you want some more details about it, you can look for those on the CMS website. There's a run-out period for claims, and then there's a performance period for those items. So if you're really interested in that, make sure you look that up. The important thing to note here, though, is that if you wind up on the qualifying participant list in your advanced APM at any of the dates during the year, you will be counted as a qualifying participant for that performance year, and you can take action accordingly. Now, if you are one of those people who's reporting under MIPS, even though you're in an APM, your MIPS weights will be a little bit different than the people who are not in an APM. Okay, we've got some illustrations here to show that, but that is still a little ways away. You probably won't find that out until sometime next year. Just keep in mind that the weights will be a little bit different for you than they will for other people.
So Adam, the question that's typically asked in the advanced APM piece is, how does CMS define risk? Risk can be defined in many different ways, but when we're talking in the context of CMS, all roads of risk lead back to Medicare HCC coding and the RAF score of a patient. This slide talks about how 65,000 ICD-10 codes are categorized into smaller subsections called risk-adjusted codes. Essentially what CMS does is it looks at chronic condition codes that come over on your claims when you submit your fee-for-service claims over to CMS, and they start to tag this and tabulate it over a yearly period, comparing risk-adjusted versus non-risk-adjusted codes. Those codes are then used as a variable in the final risk score that is calculated for a patient. So every patient that is a Medicare patient contains certain factors about themselves, such as their gender, their age, their location, all of which are variables that apply towards a risk score. CMS takes that information and adds the risk scores that come from the individual risk-adjusted codes that providers are sending out on claims to come up with a final RAF score on a patient. To give you an analogy, this is very similar to how CPT codes, or rather how RVU codes, are used to calculate the value associated with a procedure. A RAF code is a value that is used to calculate the complexity or the specificity of a diagnosis code. And why is all of this important? The reason this is important is that your risk-adjusted codes become a factor to determine the yearly reserve or the capitated rate that CMS sets as a budget line item for every patient. ACOs are familiar with this in the form of their benchmarks and their minimum savings rates that they need to hit. For those of you who are really good with HCC coding, you understand the importance of yearly review of diagnosis codes. It's an important item to focus on, and eClinicalWorks provides a lot of assistance to help our clients throughout this complex process. So Adam, we're often asked, what is the role eClinicalWorks plays in this complex world of MACRA? And I think this slide does a fantastic representation of that. Going back to our days as kids when we went out camping, and we knew whether we liked it or not, we had to get to the other side, no matter what obstacle was in front of us. What helped us at that point was maybe somebody to get us across from point A to point B. And that's really the role that eClinicalWorks wants to play and believes the role that we should play in this progression from fee-for-service towards value-based care in its biggest ever experiment with MACRA. We want our customers to know that we understand this really well. We have built solutions to help you succeed in this, and we have a ton of resources that can come out and help your practice, whether virtually or on-site, to get you across to the other side and be successful within MACRA. And with that, we want to thank you for listening in on today's session on MACRA. My name's Rohan D'Souza.
And I'm Adam Salati.
Have a wonderful day.